When we deal with neurorehabilitation, the kind of patient that I deal with primarily in adult, it is dealing mainly with multiple sclerosis, brain injury, spinal cord injury, strokes, and as I mentioned, MS. When we talk about spasticity, spasticity is the hallmark of neurologic disease. And we classify spasticity as being the result of an injury to what we call the upper motor neuron area of the nervous system, which is the brain and the spinal cord. If one has an injury to a peripheral nerve or nerve root, that is not something that causes spasticity. However, if one has an injury or medical problem, an acquired disease like multiple sclerosis that affects the brain or spinal cord, spasticity is the hallmark. Now, I am sure you all understand what spasticity is, and every one of you may have had some manifestation spasticity. However, spasticity that persists, it is like having a Charlie horse that's constant in different muscles, usually in the extremities, the legs primarily, or the arms if it's a stroke. But with MS, it's primarily in the lower extremity, in the legs. Spasticity is defined as altered skeletal muscle performance with a combination of paralysis, increased tendon reflex activity, and hypertonia. Those are a lot of big words. What it means basically is that you have increased reflex, activity, and you have an increased tone. The muscles are hard, they're tensed. They're having like a Charlie horse. What is spasticity? It's an increase in the muscle tone caused by injury of the upper motor neuron pathway. When you look at spasticity, when you look at every joints of your body, your arms and legs, they move in flexion and extension. And there's a mechanism for this. There's nerve impulse and mechanisms that instruct the arms and legs to move in a proper fashion. When part of that mechanism is knocked out, you're only left with half of the mechanism. In the arms, when you have spasticity and there's an injury to the spinal cord, the impulses that control the extension is knocked out. So it means the arm will bend, but it cannot straighten up. In the legs, it's a reverse. The leg will extend, but it cannot flex. And this causes, therefore, an imbalance. The imbalance is because there's a decrease in a neurotransmitter that's produced in the brain and spinal cord called gamma-aminobutyric acid, or in short, GABA, in the spinal fluid that transfer those signals to those various parts of the body. So when you have a decrease in the formation or the ability to have that GABA in the spinal fluid, you end up with spasticity. By the way, if you have any question at any time, just raise your hand and we'll just keep it very informal. Spasticity is the hallmark of neurologic disease that affect the central nervous system. Congenitally, we'll see it in cerebral palsy. In children, we'll see it also in the near hanging, near drowning, with cerebral anoxia, where you don't get enough oxygen to the brain. Acquire with traumatic brain injury and spinal cord injury. Static with stroke, and progressive with multiple sclerosis. Now, I have a special affinity for dealing with multiple sclerosis by virtue of the fact that personally, I also have multiple sclerosis, and I have had it for over 40 years. And I'm quite functional. So I understand the spasticity and the problem that someone with multiple sclerosis has, since I personally have had that experience. So someone can tell a doctor about spasticity, but unless that doctor understands it or has it, it's only something that you know about. It's not something that you experience. It's estimated in the world that the incidence of spasticity, that approximately 12 million people are affected worldwide. 90% of cerebral palsy patients will have some form of spasticity. That's a very significant number. There's approximately 500,000 patients with cerebral palsy in the US, and therefore approximately 450,000 of them will have spasticity. It is estimated that 80% of patients with MS will have varying degree of spasticity. By varying degree, somebody may have a very mild form of spasticity, while other will have severe form of spasticity. Therefore, there's approximately 400,000 people estimated with MS in the US, and therefore approximately 320,000 people with spasticity from MS. The incidence of spasticity with cerebral palsy, it's 3.326 per thousand, with MS 7.4 per 100,000, with stroke 183 per 100,000, traumatic brain injury 1.7 million, about 50% will have some spasticity, and spinal cord injury, about 40% will have some spasticity. Spasticity causes and results in an involuntary contraction of the muscles, of synergistic muscles. By synergistic, what it means is that in every muscle you have two motions. You have flexion and extension. That means synergistic. And what happens is that the inhibitory stimulus is knocked out. So you only have the excitatory stimulus. So if you have a muscle which is excited, it will contract. And that's what happens. The causes of the spasticity is in the imbalance. In MS, it is believed to be due as a result of autoimmune destruction of the myelin sheets around the nerve ending. It mimics GABA deficiency present in damaged nerve of spastic neurogenic disease. The effect, however, is exactly the same. It is a GABA deficiency in the spinal fluid. By deficiency, it could be actually missing or ineffective, the existing GABA. Spasticity, again, to emphasize this, is due to decrease in inhibitory input. It is a disease of GABA deficiency. Now, you have GABA produced in the many parts of the body. You have GABA produced in the gut. You have GABA produced in other parts of the body. There's GABA that you can find in the, naturally, and there's a supplement with GABA. However, it is not effective unless it gets in the spinal fluid.
What is GABA?
GABA is gamma-aminobutyric acid. It is a neurotransmitter which is present in the body, primarily in the spinal fluid, and it acts as a transmitter of impulses, sending signals to different parts of receptor area on the spinal cord that permits the motion. There's a deficiency, like a diabetic may be missing insulin, and therefore you cannot manage the sugar. When you have a GABA deficiency in the spinal fluid, it's as a result of a neurologic injury, and in turn it creates the spasticity, and with spasticity, therefore, you cannot move properly. Because if your leg is spastic and you have your toes are pointing down and you're toe walking and you cannot turn your foot upward, you cannot have a proper gait. To have a proper gait, you must have a heel strike first. If you cannot move your hip properly, you cannot properly balance, you cannot transfer. GABA, gamma-aminobutyric acid, is a neurotransmitter which carries descending inhibitory input from the subcortical nucleus in the brain or inhibitory message to GABA site in the spinal cord. To simplify it, in the brain there's a message that goes out. That message is transmitted not necessarily through a cable, but sometimes through a chemical, a neurotransmitter. And that neurotransmitter will carry that impulse to the proper area in the spinal cord where it will permit the proper response. Okay, what are the limitations associated with severe spasticity? Functional impairment, pain, fatigue, sleep difficulty, joint contraction, bowel and bladder dysfunction. Why pain? If you have a muscle that's in spasm continuously, that's painful. If you tighten a muscle, if one exercise and you have a tight muscle, after a period of time the lactic acid builds up in it, that becomes very painful. If that muscle does not relax, that's painful. You can have people with severe, late term Charlie horse, tremendous amount of spasm, which is very painful. So spasticity causes pain. I see many patients with MS that come in where their complaint is pain and difficulty with mobility. Well, you don't treat that with pain medication because it does not work. All you make them is dependent on pain medication. You deal with the replacement that causes the spasticity so as to reduce the spasm and in turn give the patient relief. Fatigue. If you exercise for 10, 12 hours a day, you're going to be pretty fatigued. Well, imagine those muscles working all the time. You're going to be fatigued from that. So fatigue with MS is one of the major features. Fatigue and pain. Mobility. Joint contracture. If you have an area of an extremity which is tight all the time, that joint will contract. Eventually you'll get bony deposit in there, calcium deposit, and that joint will become contracted. You see this especially in kids that have cerebral palsy, or you see this in people that have had severe cerebral anoxia where they have not had oxygen to the brain. A near drowning, they become so spastic and they become contracted. There's difficulty with positioning, being able to sit properly in a wheelchair, sit properly in a chair, in a comfortable position. There's difficulty with walking. If your leg is in spasm at the hip or the knee or the ankle, how can you walk properly? Mobilizing a wheelchair, transferring to and from the bed, to the toilet, the car. There's reduced intimacy, vocational disability, and social isolation. So these are all as a result of spasticity. Now we're dealing with severe spasticity, and not everyone has that severity. The symptoms is a feeling of tightness, may cause painful spasm in the extremities, stiffness making tasks difficult to perform, painful muscle contraction, involuntary crossing of the legs. Some of the muscles that are affected with spasticity are what we call the adductor muscle, so that when you walk, it will pull the leg toward the middle. So someone trying to walk will end up scissoring. Joint deformities and muscle fatigue. I cannot emphasize enough the issue of fatigue. Deleterious effect of spasticity, again, it interferes with positioning, with mobility, with comfort, hygiene, and impaired dexterity. There's an increased metabolic demand on the body because if your muscles are working continuously in spasm, there's inadequate nourishment. And a patient that has severe spasticity requires increased caloric intake because you're burning up a lot of calorie from that energy expenditure. The spontaneous spasm might interfere with sleep or duration of wheelchair use. I have patients that have difficulty sleeping because as they're laying down, they go into spasm. That becomes very difficult. Spasm can also lead to skin breakdown. Somebody's in bed and their pressure from those muscles against the sheet can cause irritation and skin breakdown. And the impaired healing of surgical wounds due to tension along suture line. Somebody has surgery, there's delay in the healing because the suture line are under tension. There's some beneficial effect from spasticity. It may help with maintaining posture. If your legs are like spaghetti and just wobbly, you cannot stand. You need a certain degree of spasticity. So you need to balance that with a comfortable degree of spasticity that helps you with your balance. It helps with the circulation, vascular circulation. If those muscles are continuously in contraction, they help to squeeze the blood in the blood vessels, and there's less chance of having a blood clot. Preservation, muscle mass, and bone mineral density. Again, if you're exercising all the time those muscles with spasticity, the bone density will be better. And it prevents deep vein thrombosis or blood clots. We assess a patient with spasticity by feeling the resistance of the muscles to passive lengthening in its most relaxed state. This is a technique. And usually I don't do it myself, I can, but I usually have trained physical or occupational therapists that will do those measurements. And we measure this by calling it the Ashworth, modified Ashworth scale. There's a scale of measurement, and we measure this by that scale, and we can determine what the changes are. What happens with some of the patient is what we call a clasp knife response. The arm will start to relax, and then it stops, and then it claps, suddenly relaxes. And just like opening a pocket knife. Secondary effect, if there's impaired function will follow increased spasticity, loss of muscle fiber will increase the weakness, and secondary changes lead to muscle contracting if treatment is delayed or absent. Our goal in spasticity management is to improve the gait, improve hygiene, improve activities of daily living and ease of care, either for the patient or the caregiver. Decrease the spasm frequency, in turn, therefore, decreasing pain and fatigue. Promote tone reduction, increasing range of motion, improve joint positioning. Increasing mobility. It complements rehabilitation therapy or treatments such as physical therapy, occupational therapy, and speech therapy. Okay, what are the treatment options that we deal with? The common treatment option offered at Spasticity Management Center is number one, the mainstay of any treatment is physical therapy, is maintaining exercise of management to mild to moderate impairment. Muscle with severe spasticity are more limited in their ability to exercise, however. And secondary complication, again, contracture, deformity, postural asymmetry. Pain and spasticity. Spasticity will limit the range of motion around the joint with the resultant musculoskeletal pain. So when I see a patient coming in complaining of pain that has MS or neurologic disease, I don't treat the pain. I try to look and see what the degree of spasticity, and managing the spasticity will help to reduce the pain. Goal of the treatment may not be the complete elimination of spasticity, but titrating to get the best result to permit better function. If you knock out all the spasticity, the patient will be too weak to even stand. So you have to manage that. Physical and occupational therapy are designed to reduce the motor tone, improve range of motion mobility, increase strength and coordination. The therapist, however, should be familiar with neuromuscular facilitation and neurodevelopmental techniques and physiology. Not every therapist is trained in the management of the kind of exercises that one has when there's spasticity, because certain exercises will actually increase the spasticity, while certain other exercise will reduce it. And one has to be trained in that kind of techniques. Other non-pharmacologic management without medication. Icing some of the joint may be of muscle may be of benefit. Casting, serial casting, sustained stretching, and inhibitory pressure. Again, a therapist must be well familiar with the appropriate bracing and the potential complication, a good orthotist for braces, and the wheelchair expertise. You don't just give someone a wheelchair, there must be a specific wheelchair prescription. Pharmacologically, we have a number of medications that we use in addition to physical therapy. The most common one being baclofen, dantrolene, tizanidine. These are medications that right now one can take orally. Botox is appropriate for patients with focal spasticity, such as a patient with a stroke that ends up with a clenched fist, where you can inject those areas to try to reduce the spasticity. Dantrolene, one of the medication that I mentioned, will reduce spasticity at the muscle, but it is not physiologic. What it does, since you have increased tone, it knocks out the normal response, let's say a flexion, as opposed to increasing the extension. Dantrolene is a good drug, however, it has a lot of side effects, especially on the liver, and we have to be very conscious of that. So one who has liver disease cannot really take dantrolene, and dantrolene cannot be given for a long period of time. Tizanidine is the newest drug used for spasticity. It works at the muscle level. It can be effective in some patients. Baclofen works by interacting with neurons that use GABA as a neurotransmitter. It inhibits the spinal reflex. The oral dose orally is 5 to 10 milligrams 2 or 3 times a day. The dosage may be increased by 5 to 10 milligrams per week, and the maximum dose is 80 milligrams a day, even though a lady here was telling me she's taking what, about 3 times that dose a day, which is 150 a day. That's a huge dose. Other drugs use gabapentin, tiagabine, diazepam, catapres. They all have certain degree of value, and it's worth a try if you don't have side effect with it. Invasive procedure. Sometimes you have to give medication intravenously, or you have to do some injection or actually chemodenervation. Botox or botulism toxin is used for denervation, and it inhibits what's called the acetylcholine, which is another neurotransmitter, at the muscle level, at the myoneural junction. Surgery. Some patients will require tendon release, joint release for contracture, and some patient will be a candidate for selective dorsal rhizotomy, where a neurosurgeon will cut some nerve root fiber that sends sensory messages up the spinal cord. Baclofen. Baclofen is my drug of choice. The reason for it is that it is the only medication available for GABA deficiency. Gamma-aminobutyric acid, as I mentioned, is deficient in the spinal fluid. It's like a diabetic not having insulin. And the best way to provide baclofen is not orally, unless if you try it orally you get a good response, which not always works. You try it, however, orally, because the dosage, if you're using 80 milligrams a day by mouth, and it's not fully effective. When you use baclofen and you inject it into the spinal fluid directly, you provide it in microgram. So it's 1/1000th of the dosage. When I heard of a lady here taking 150 milligram of baclofen by mouth, and she might only require 150 microgram, 1/1000th of that, if it were into the spinal fluid. Why? Because in the spinal fluid, that will go immediately to the GABA site in the spinal cord and be so much more effective. What is intrathecal baclofen therapy? It is a treatment for individuals with severe spasticity due to multiple sclerosis, brain injury, stroke, cerebral palsy, and spinal cord injuries. Yes, sir.
When you take baclofen and you say that it is most effective at the time when you're involved with the spinal cord, is it possible to inject right into the spine?
Yeah, that's what we do.
As opposed to the oral?
That's correct. And that's what I'll go into. That's what I will go into. It is a non-destructive, adjustable therapy that can be reversed, and the way we provide it is after we have had the patient take baclofen by mouth. If they have side effect from baclofen by mouth, or if the baclofen is not effective like we would like, we do what's called a baclofen trial, where we bring the patient to the outpatient department, and in the surgical suite we do a spinal tap, and we inject a very small dose of baclofen into the spinal fluid, 50 microgram. That's a minuscule dose. However, we then measure the response to the spasticity every half hour to 1 hour for a period of 4 hours and see what the results are. If the patient shows positive response to that trial, then the patient's a candidate for what we call a baclofen pump. We use an implantable, programmable pump, which is about the size of a hockey puck, which is actually a reservoir. It is inserted in the tissue of the abdomen after the patient has passed the baclofen trial. And from that reservoir, there's a very fine tube called a catheter, which is threaded through the back into the spinal canal, and we anchor it at a different level of the spine. And that pump is a computer, and it's a reservoir. And the pump is programmed to deliver baclofen, even though there's other pumps being used for pain, for other treatment, for the insulin, that are similar, and they produce or they deliver medication based on what's programmed in there on a 24/7 basis. Okay, if you look on the bottom right, that's a pump. It looks like a hockey puck. If you look in the center of it, there's what we call a port, which is an access area. It is sealed with a special kind of material. However, through the skin, we have a special needle that we put, goes right into the port, and the pump is refilled. If we have question about the pump working properly, there's another area by the top there where there's another port where we can put another kind of needle, can put a dye in there, and try to look under fluoroscopy to see if the flow is appropriate or not. But as an average, the patient will come in from 2 to 4 months for pump refill. As I said, we do a baclofen trial first. The catheter is inserted in the low back and advanced to about the mid-back. There's a small abdominal incision made for the pump. The catheter is connected to the pump. This, like any surgery, even though it is an outpatient, relatively minor surgery, every surgery can have complications. So one could develop infection, headache, spinal fluid leak, meningitis, paralysis. That is extremely rare, but it's something that we warn patients anyway. We titrate the dosage of the medication. During that period of time, we increase the physical therapy and the therapy to the patient to maximize their ability to be more functional. That is basically the pump. This is the catheter that attached to the pump that goes into the spinal canal. This is the small computer, handheld computer, that is the analyzer that speaks to the pump. We program this, we can speak to the pump, and then we do a printout from that. We have a machine that does a printout so that we know exactly the date, how much medication's in there, the dosage, when's the next date of refill, and we give the patient a copy of that. Baclofen overdose sometimes can happen. Someone could have an overdose. Usually it manifests with somnolence, being sleepy, some respiratory difficulty, low blood pressure, seizure, loss of consciousness, or coma, hypothermia. That is very rare, but like with anything, we need to give you warning. When you watch a TV advertisement for anything, now you get all kind of warnings about all the kind of things that could happen.
Side effects are worse than the medication.
If when there's withdrawal, there's basically 3 things that we see. By withdrawal, when there's not enough medication going in, if someone was getting medication, and let's say for whatever reason, the tube got kinked, and you're not getting the proper dosage. Remember, intrathecal baclofen, ITB, we call that ITB, itchy, twitchy, and bitchy. Because that's what happened to the patient. They get itchy, they get twitchy, and they get bitchy. The muscles get tight, and we know at that time that it's probably from withdrawal. So basically, this is my dog and pony show. Anyway, thank you very much, everyone. And